Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
You know that feeling, right? You had a long day, maybe on your feet for hours, or perhaps you've been glued to your desk. By evening, your legs just feel heavy, tired, achy.
Yeah, that's pretty common.
It is. And it's easy to just dismiss that discomfort as, part of a busy day, something we all experience. But what if that persistent ache is actually a subtle whisper from your body? A sign of something much more significant, often progressive, and surprisingly widespread that's been overlooked for far too long.
It's true. And that's precisely what we're diving into today. Chronic venous insufficiency, or CVI.
CVI, okay.
It's a condition that's far more than just, say, a cosmetic concern like varicose veins. Its impact on health and quality of life is actually pretty profound.
Our mission today is to truly unpack the full scope of CVI for you. We're going to explore its hidden origins in your body's intricate plumbing system, reveal its surprising, far-reaching health and economic consequences.
Which are quite significant.
Definitely. And show you how it's now diagnosed with remarkable precision and introduce you to the revolutionary modern treatments available. By the end of the deep dive, you'll walk away well-informed about a condition affecting a huge portion of the population, often without them even realizing it. So, beyond what you might see externally, like, spider veins or maybe varicose veins, how does CVI fit into the broader picture of venous conditions? It seems like there's a specific language we need to understand here.
There absolutely is. And using the precise terminology is actually crucial for understanding the progression of the disease. At the broadest level, we talk about chronic venous disorder. That basically includes any abnormality in the venous system. Simple as that.
Okay, any abnormality.
Then when those abnormalities start to show up with clinical signs or symptoms, things like pain, heaviness, visible swelling, then we're dealing with chronic venous disease, or CVD.
Right, so that's when you start feeling or seeing things.
Exactly. And chronic venous insufficiency, CVI. That represents the most severe form of CVD. It's characterized by functional changes leading to significant issues like persistent swelling, visible skin changes, or even open sores, ulcers.
Wow, so it's a clear progression.
It is, and recognizing this progression early is absolutely key.
And the sheer scale of this problem truly underscores why that early understanding is so vital. What's the prevalence we're talking about here? How many people are actually affected?
It's actually astounding how pervasive this condition is, and how its true impact, both on individual health and, frankly, the global economy, often goes unrecognized.
Really?
Globally, some form of chronic venous disease affects up to, get this, 83.6% of the population.
Just from 3%, that's enormous.
It is. To put that in perspective, common varicose veins, which are clinical stage C2 on the classification system we'll get into, they're present in 30 to 40% of adults. And the most severe part, venous ulceration, can develop in up to 6% of those individuals.
The scale of that impact is quite significant. And what does that economic burden actually represent in terms of healthcare resources?
Oh, it's immense. In the U.S., direct medical costs range from $150 million to over $1 billion annually.
$1 billion, wow.
Yeah. And in Western Europe, estimates are EUR 600 to 900 million per year. That represents up to 2% of total healthcare spending in some countries.
2% of the entire healthcare budget.
Can be, yeah. But here's the kicker.
Okay.
Nearly 90% of this huge financial burden comes just from managing venous leg ulcers, the end-stage complication.
90% just from ulcers. That seems disproportionate.
It's a profound disconnect, isn't it? It highlights how relatively inexpensive early management can be, yet delayed diagnosis and treatment lead to these exponentially higher costs and a major drain on healthcare systems.
Okay, let's unpack this further. It's not just about what you see on the surface, is it? You mentioned health impact.
What's fascinating here, and quite sobering actually, is how pervasive this condition is and how its true impact often goes unrecognized, even beyond the legs.
Beyond the legs? How so?
Well, there's emerging evidence linking CVI to overall health. Some large studies have found that CVI is associated with an increased risk of all-cause mortality.
Wait, really? Increased risk of death, independent of things like heart disease risk factors.
Yes, independent of traditional cardiovascular risk factors. This elevates its importance beyond just a problem with your legs.
Wow.
It suggests CVI might be a subtle indicator of broader systemic inflammation or maybe vascular issues impacting overall survival.
That completely reframes how we should think about CVI. It's not just achy legs or varicose veins.
Not at all. It truly highlights how a seemingly simple mechanical issue can spiral into a complex systemic problem.
And that systemic problem starts with our own body's battle against gravity, doesn't it? Our lower limb venous system is, well, quite a clever piece of engineering.
It really is. Think of your lower limb venous system as this low-pressure network. It's got three main interconnected parts: superficial veins just under the skin.
Like the ones you might see.
Right. Then the deep veins, which are encased in muscle, and perforating veins connecting the two. The deep veins are the workhorses, crucial for blood return, handling over 90% of the blood volume.
And getting blood back up to the heart from the legs is tricky.
It is, fighting gravity all the way. So we rely on two critical mechanisms. First, delicate bicuspid venous valves. Think of them like little one-way gates inside the veins.
Stopping blood from flowing backward.
Precisely. Preventing what we call reflux. Second, we have the calf muscle pump, often called the peripheral heart.
The peripheral heart, I like that.
Yeah. When your calf muscles contract, like when you walk, they squeeze those deep veins, pushing blood upwards. When they relax, pressure drops, drawing blood from the superficial system into the deep system.
So CVI happens when one of those systems fails.
Exactly. When either the valves fail or the pump isn't working effectively, that's when the problems start.
So if those one-way valves aren't closing properly, or if the calf muscle pump isn't effectively squeezing, what's the immediate physiological consequence? What sets off that cascade of problems we see in CVI?
Right. The central driver, the core insult of all CVI manifestations, is sustained ambulatory venous hypertension.
Okay, that sounds technical. Break that down.
Yeah, it just means continuously high pressure in the veins, especially when you're upright and moving around ambulatory.
High pressure. Got it. And why does that happen?
Primarily due to two reasons. The most common one is valvular incompetence.
The valves failing.
Yes, the valves don't close properly, allowing blood to flow backward to reflux. This negates the effect of the muscle pump too.
And can that just happen, or is there a cause?
It can be primary, maybe just a congenital weakness in the valve structure, or it can be secondary, meaning it's caused by something else, most often damage after deep vein thrombosis, a DVT. That can lead to what's called post-thrombotic syndrome.
Okay, DVT is a big one. What's the second cause of high pressure?
The less common cause is venous obstruction, so an actual blockage of blood outflow. Again, maybe from DVT scar tissue or even external compression, like in a condition called May-Thurner syndrome, where an artery presses on a vein.
So this isn't just about plumbing, is it? It sounds like that high pressure actually triggers a much more complex biological reaction in the body.
It absolutely does. This is really key to understanding CVI. Sustained venous hypertension isn't just mechanical. It ignites a chronic inflammatory response.
Inflammation. Okay, how does that work?
Well, the high pressure and the altered blood flow activate the endothelial cells, the cells lining the inside of the vein.
They get switched on.
Sort of, yeah. They become sticky, attracting circulating white blood cells, mostly neutrophils and monocytes. These white blood cells then glom onto the vein wall and actually migrate out into the surrounding tissue.
And then what?
Once they're activated out there, they unleash this destructive cocktail of inflammatory chemicals, enzymes, things like cytokines, reactive oxygen species, MMPs.
Sounds nasty.
It is. Think of them as tiny wrecking balls, constantly damaging the vein walls and the valves themselves. This causes the veins to dilate, which worsens the reflux.
Ah, so it feeds itself.
Exactly. It creates this self-perpetuating vicious cycle. That's why CVI almost always gets worse over time if it's not treated.
So to put that inflammation in simpler terms, is it almost like the body is constantly attacking its own vein walls from the inside out?
That's a pretty good way to think about it, yeah.
And what visible consequences does this inflammation have on the skin and the surrounding tissues? We talked about ulcers later on.
Right. At the microcirculatory level, in the tiny capillaries in the skin, this inflammatory cascade has devastating effects. The increased capillary permeability, basically leaky capillaries caused by that endothelial dysfunction, allows fluid, proteins, even red blood cells to leak out into the surrounding tissue. That causes edema or swelling.
Okay, the swelling makes sense.
Then, when those leaked red blood cells break down, they release iron pigment, hematodirin. That stains the skin, causing that characteristic brownish discoloration you often see around the ankles.
Ah, so that's where the brown color comes from.
Exactly. And the chronic edema and inflammation also lead to tissue hypoxia, lack of oxygen. This activates cells called fibroblasts, which lay down scar tissue. The skin and the tissue underneath harden, become fibrotic. We call that lipodermatosclerosis.
Lipodermatosclerosis. Feels woody, I read.
It can, yeah.
Ah.
And this hard, fibrotic, poorly oxygenated tissue is incredibly fragile. It's prone to breaking down, and that ultimately leads to the formation of venous leg ulcers.
It's truly incredible how intricate our body systems are, fighting something as fundamental as gravity.
Right.
And how one small glitch, like a faulty valve, can cascade into such widespread health issues. And I understand there's a strong genetic component to this. Some people are just more predisposed.
Yes, absolutely. Family history is a significant non-modifiable risk factor.
Non-modifiable meaning you can't change it.
Correct. Studies suggest if both your parents have CVD, your chance of developing it could be as high as 90%.
90%? Wow.
Yeah. And research has pinpointed specific genes. A key one implicated is called FOXC2. It's critical for how our venous and lymphatic systems develop, and particularly for valve formation.
So a variation in FOXC2 could make your valves weaker from the start.
Potentially, yes. And polymorphisms, variations in other genes related to inflammation or tissue structure, have also been identified. It highlights the complex polygenic nature, multiple genes involved in CVI susceptibility.
So when we talk about who's at risk, what's the balance here between the hand we're dealt by genetics or age and what we can actually influence through our choices?
That's a great question, because understanding the risk factors is really crucial for both prevention and management. We tend to categorize them into non-modifiable, the things you can't change, and modifiable, the things you can potentially influence.
Let's start with the non-modifiable factors first, the ones we're stuck with, so to speak.
Right. So non-modifiable includes increasing age. Just like other tissues, vein walls and valves naturally weaken over time.
Makes sense.
Female sex is also a well-established risk factor. It's believed to be due to hormonal influences, particularly estrogen and progesterone, which can decrease vein wall elasticity and tone.
Hormones play a role.
Okay? Then there's that strong family history or genetic predisposition we just talked about with genes like FOXC2.
Right.
And finally, a history of deep vein thrombosis, or DVT, or even significant leg trauma is probably the most common cause of secondary CDI, caused by something else damaging the veins.
Because the DVT damages the valves or blocks the vein.
Exactly. It leads to damaged valves or chronic obstruction.
Okay, so age, sex, genetics, and past medical events like DVT are largely out of our hands.
Yeah.
But what about the factors we can influence? For someone like, say, a barista who spends their whole workday standing, what modifiable factors might come into play?
Good example. On the modifiable side, obesity is a major one. Increased body weight, particularly abdominal obesity, significantly increases intra-abdominal pressure.
Which makes it harder for blood to get back up from the legs.
Precisely. It impedes venous return. Pregnancy also plays a role, partly due to hormonal changes, relaxing vein walls, increased blood volume, and later on, the physical compression of the large veins in the pelvis by the growing uterus.
Okay.
Then there's prolonged standing or sitting, like your barista example. This leads to static columns of blood in the legs, increasing venous pressure and putting constant stress on the valves.
So movement is key.
Absolutely. Which leads to the next one, physical inactivity. If you're not moving, your calf muscle pump isn't working effectively.
Right, the peripheral heart isn't pumping.
Exactly. Smoking is another one. It's a known risk factor for all sorts of vascular diseases, and it contributes to endothelial dysfunction, damaging that inner lining of the veins.
Okay, smoking too.
And lastly, certain hormonal factors beyond pregnancy, like the use of oral contraceptives or estrogen therapy, can also influence venous hemodynamics and potentially increase risk in susceptible individuals.
It sounds like many people might be experiencing subtle symptoms, those early whispers, without ever connecting them to CVI. So as CVI progresses, what visible signs emerge that might prompt someone to realize, hang on, this is more than just tired legs?
That's an excellent point.
Yeah.
CVI presents on this really wide spectrum, from very subtle complaints to severe debilitating issues. It's so important to recognize the progression. And there's actually a universal language we use for this called the CEAP classification system.
Ah, yes, CEAP. Before we get into the classification system itself, what are those early whispers the body gives us? What are the symptoms people might feel?
Okay. In the early stages, patients often report symptoms related to that venous congestion we talked about, the pooling blood. So a feeling of heaviness, aching, fatigue, general discomfort in the legs.
Just feeling off.
Yeah, exactly. Especially after long periods of standing or sitting. You might also experience itching, cramping, particularly at night. That's quite common. Or even restless leg syndrome can be linked.
And is there anything specific about these symptoms?
A key diagnostic feature, something that really points towards a venous cause, is that these symptoms are typically relieved by rest and, crucially, by elevating the legs.
Ah, because that helps drain the pooled blood.
Precisely. Gravity helps you out there. This helps distinguish it from, say, arterial pain, which often gets worse with elevation.
Okay, that's a really useful distinction. And then as it progresses, what are the visible changes we start to see on the skin? This is where CEE comes in.
Exactly. This is where the CEP classification system helps us describe the visible progression from C0 up to C6. C0 means you have no visible or palpable signs of venous disease, even if you have symptoms like aching or heaviness.
So you can feel it, but not see it yet.
Right. C1 involves telangiectasias, what most people call spider veins, those tiny red or purple threads less than 1 millimeter wide, or reticular veins, which are slightly larger, bluish veins between 1 and 3 millimeter.
Okay, spider veins are C1.
C2 is when you see varicose veins. These are the larger, dilated, often tortuous veins, usually more than 3 millimeter wide, that actually bulge from the skin surface.
Right, the classic varicose veins.
Then in C3, we start to see edema, or swelling, that's clearly caused by the venous issues. It's usually pitting edema, meaning if you press it, it leaves an indentation and typically starts around the ankles that might move up the calf. It's often worse at the end of the day.
Swelling is C3.
Then, as that chronic inflammation and microcirculatory failure continue, we get into the more advanced skin changes, the C4 category. C4A brings things like hyperpigmentation, that brownish or brawny discoloration, usually in the gaiter area around the ankle, from the hemosiderin staining we mentioned. Or you might see stasis dermatitis, also called venous eczema red, itchy, scaly skin.
So skin color changes and texture changes.
Exactly. C4B is more severe skin change. This includes lipodermatosclerosis, where the skin becomes hardened, thickened, fibrotic, feels kind of woody. Or you might see atrophy blanche. These are localized, often circular, white, atrophic, almost scarred-looking plaques. They can be quite painful and are often precursors to ulcers.
Wow, the skin really takes a beating.
It does. And sometimes grouped under C4, specifically C4C now in the revised classification, is corona phlebitictica. This is a fan-shaped pattern of lots of tiny intradermal veins on the ankle or foot. It's a sign of quite advanced disease.
Okay, and then the final stages.
Right, the end-stage disease involves ulceration. C5 means you have a healed venous ulcer. You can see the scar tissue where an ulcer used to be.
So it closed up.
Yes. But C6 is an active venous ulcer. This is an open skin defect, a wound. They typically occur around medial malleolus. The inner ankle bone are often painful, prone to infection, notoriously difficult to heal, and unfortunately have a high tendency to recur.
That sounds incredibly difficult to live with.
It absolutely is. It severely impacts quality of life. And very rarely, a chronic ulcer can undergo malignant transformation into a type of skin cancer called a marginal ulcer.
So this CEP system really gives everyone from patients to doctors a clear, objective way to understand where someone is in the disease progression. It's not just vague descriptions.
Exactly right. The CEAP classification, first developed back in 1994 and updated more recently in 2020, is the globally accepted standard. It has 4 parts: clinical C, etiological E, anatomical A, pathophysiological P, but the C class we just went through is the most widely used day-to-day.
And it guides treatment.
Absolutely. It provides that objective stepwise framework. It correlates directly with disease severity and definitely helps guide treatment decisions. For example, interventional treatments to fix the underlying reflux are typically considered for patients at C2 varicose veins or higher. And obviously, aggressive wound care is essential for anyone at C6 with an active ulcer.
Okay, so once someone recognizes these signs or symptoms, maybe using that CAP scale as a guide, where does the diagnostic journey even begin for CVI? Is it just a quick look at the legs, or is there more to it?
Oh, there's definitely more to it than just a quick look, although observation is key. It absolutely starts with a detailed patient history and a thorough physical examination.
What kind of history?
We need to really understand the nature of your symptoms, what they feel like, when they occur, what makes them better or worse. We review all those risk factors we talked about. Family history, any past DVT or leg injury, pregnancies, occupation, smoking history, obesity.
Getting the full picture.
Exactly. And the physical exam is crucial. Ideally, it should be performed with the patient standing because that allows for maximal vein distension, making problems easier to see and feel.
Makes sense.
We inspect and palpate for all those CEP signs we just discussed: spider veins, varicose veins, swelling, skin changes, looking for ulcers. We also always check the pulses in the feet to rule out significant peripheral arterial disease, or PAD.
Why is checking pulses important here?
Because if someone has significant arterial disease, it can affect treatment choices, especially compression therapy, which might not be safe in severe PAD.
Good point. Okay, so you've done the history and the physical exam. What's next? I know you mentioned duplex ultrasonography earlier as being really important.
Yes, once that initial assessment is done, the clear gold standard for diagnosing and evaluating CVI is duplex ultrasonography, or DUS.
Gold standard. Why is it considered so essential? What does it actually show?
DUS is really the cornerstone because it's non-invasive, completely safe, relatively inexpensive, and gives us both anatomical and hemodynamic information in real time.
Anatomy and hemodynamics.
Yeah, so it combines B-mode ultrasound, that's the standard grayscale picture, which gives a detailed view of the veins themselves. We can see their size, whether they compress easily, look for any signs of past DVT, like thickened walls or old clots.
Okay, the structure.
Right. And then it combines that with pulsed wave Doppler, which assesses blood flow specifically, the direction and velocity of blood flow within the veins.
So it sees how the blood is moving.
Exactly. And that's how it shows the reflux, that backward flow you mentioned earlier, with such precision.
How does it actually do that? How does the test work when you're having it done?
Well, the primary goal of DUS for CVI is to identify and map that venous reflux accurately. The sonographer, the person doing the scan, uses provocative maneuvers while you're typically standing, or sometimes tilted feet down on a table, to stress the veins.
Provocative maneuvers, like what?
Usually they'll squeeze your calf firmly and then suddenly release the pressure. Or sometimes they'll have you do a Valsalva maneuver, like bearing down.
And what does that show?
In a healthy vein with competent valves, when the calf is squeezed, blood flows up towards the heart, and when the squeeze is released, the valve snaps shut and flow stops almost immediately.
Okay.
But in an incompetent vein, after the compression is released, the Doppler signal will show blood flowing backward down the leg, away from the heart. The duration of this backward flow, this reflux, is measured precisely.
Is there a cutoff for what's considered abnormal?
Yes, there are specific quantitative criteria. Pathologically significant reflux is generally defined as lasting more than 0.5 seconds in the superficial veins, like the saphenous veins or the perforating veins, and it's longer, more than 1.0 a second, in the deep veins, like the femoral or popliteal veins.
So it gives you a definite yes-no on reflux and where it is.
Absolutely.
Yeah.
Its clinical utility is immense. It confirms the presence and severity of reflux. It identifies the specific veins involved, the source of the problem. It can rule out obstruction. And it essentially creates a detailed reflux map of the leg's venous system.
A reflux map. I like that.
And that map is absolutely essential for planning any kind of intervention because you need to target the primary source of the high pressure. You don't want to just treat the visible varicose veins if the underlying main vein is the real problem.
This raises an important question. Why is DUS considered the gold standard? It seems it's because it doesn't just show you the problem, it maps it out with incredible precision.
That's exactly right. It gives us that crucial anatomical roadmap combined with the functional information about flow direction. It's accurate, non-invasive, and provides the detailed information needed for effective treatment planning.
So DUS gives us the map of where the problem is, but I hear there are other tools that can tell us how well the whole system is actually performing when you're moving, giving us maybe a more complete functional picture. What are those?
That's a great point. Sometimes there's what we call an anatomy-symptom mismatch. Someone might have significant reflux shown on DUS, but relatively few symptoms, or vice versa.
Right.
And that's where complementary tools come in. Air plethysmography, or APG, is one such test. It's non-invasive and gives a more global assessment of the limb's venous function by measuring changes in calf volume during specific exercises or maneuvers.
Calf volume changes. How does that tell you about vein function?
Well, APG provides several parameters. For example, the venous filling index, or VFI, measures how quickly the calf refills with blood, which reflects the overall amount of reflux in the limb. The ejection fraction, or EF, tells us how effectively the calf muscle pump is working to push blood out. And the residual volume fraction, or RVF, measures how much blood is left behind after exercise, which correlates pretty well with the actual venous pressure.
So it's quantifying the overall performance of the system.
Exactly. While DUS gives us the anatomical map of where the reflux is, APG helps bridge that anatomy-symptom mismatch by quantifying the functional impairment. It provides a more complete physiological picture alongside the DUS findings, helping to understand the real-world impact of the reflux on the limb's hemodynamics.
Okay, that makes sense. DUS for the map, APG for the overall function. And for really complex cases or issues way up high in the deeper veins, there are even more advanced imaging options, right?
Yes. For those more complex situations, especially when we suspect problems in the deep veins of the thigh, or, importantly, the iliac veins in the pelvis, or the inferior vena cava in the abdomen areas, that can sometimes be hard to see clearly with DUS, we have other tools.
Like what?
Contrast venography used to be the gold standard many years ago. It involves injecting dye directly into the veins and taking x-rays. It's invasive, though, and DOS has largely replaced it for routine evaluation of reflux. But it's still sometimes used for planning complex venous reconstruction surgeries.
Okay, less common now. What else?
CT venography, CTV, and MR venography, MRV, are invaluable. These cross-sectional imaging techniques are excellent for visualizing those large central veins, the iliac veins, and the vena cava. They're particularly good for diagnosing venous obstruction, whether it's from old DVT scarring or external compression like May-Thurner syndrome.
So CT and MRI can see blockages higher up.
Precisely. And then there's intravascular ultrasound, or IVUS. This is a catheter-based technique where a tiny ultrasound probe is inserted directly inside the vein.
Inside the vein.
Wow. Yeah. It gives a detailed 360-degree view of the vein wall from the inside out. It's considered superior to venography for assessing the precise degree of stenosis, or narrowing, in central veins, and is increasingly used during procedures like stenting to ensure accurate placement and optimal results.
So a whole toolkit depending on the complexity.
Exactly. DUS is the workhorse. APG adds functional context, and CTV, MRV, and IVUS are reserved for more complex, deep, or central venous issues.
Okay. Once we've uncovered the truth about what's happening inside using these tools, the good news is the world of CVI treatment has undergone a genuine revolution. What does that look like today? It's not just surgery anymore, right?
That's absolutely right. The management of CVI is multifaceted, and it really has changed dramatically over the last couple of decades. But it always starts with foundational conservative measures for every single patient. These are crucial for managing symptoms and trying to prevent progression, regardless of what else is done.
What are those basic day-to-day things someone can do to manage CVI conservatively?
Well, lifestyle modifications are key. Simple things like regularly elevating your legs above the level of your heart for short periods throughout the day. That uses gravity to help drain the veins.
Okay, elevation. What else?
Regular exercise, particularly activities that activate the calf muscle pump, like walking, swimming, or cycling, is incredibly beneficial.
Get that peripheral heart working.
Exactly. Weight management is also vital, especially if obesity is a factor, as losing weight reduces that intra-abdominal pressure that hinders venous return.
Makes sense.
Avoiding prolonged immobility is important too. If you have a job that requires long periods of standing or sitting, try to take frequent breaks to walk around or at least do some calf pump exercise.
Little ankle flexes under the desk.
Even that helps. And for those with more advanced CVI, especially with skin changes, meticulous skincare is paramount. Keeping the skin well moisturized helps prevent cracking, fissures, and potential infections.
Good basic habits. And then there's compression therapy, which I know is often seen as the absolute cornerstone of conservative management. How does it work exactly?
Compression therapy is indeed the cornerstone, particularly for managing symptoms like edema and for healing and preventing ulcers. By applying external pressure to the leg, it essentially counteracts that high internal venous pressure. It helps reduce edema by squeezing fluid back into the circulation. It also improves the efficiency of the calf muscle pump when you walk, and it can even reduce the amount of reflux by physically narrowing dilated superficial veins.
So it helps in multiple ways. What kinds are there?
The most common form is graduated elastic compression stockings. These provide the highest pressure at the ankle and gradually decrease the pressure up the leg, which helps encourage upward blood flow. They come in different pressure classes, like 20-30 mmHg or 30-40 mmHg, depending on the severity of the CVI.
Right, the tight stockings.
There are also inelastic bandages, like Uniboots, which provide very high pressure when you're moving but low pressure at rest. These are often used for managing significant edema or healing ulcers. And then there are intermittent pneumatic compression, IPC devices, sleeves that inflate and deflate to mechanically squeeze the leg. These can be really helpful for patients with limited mobility or those with refractory ulcers.
But if it's so effective, what's the catch? I hear adherence can be a real issue. Why isn't everyone just sticking with it? What are the real-world challenges patients face?
You hit on an absolutely crucial point. The evidence supporting compression therapy is incredibly robust. It significantly helps heal ulcers and dramatically reduces their recurrence. However, but poor patient adherence is a major barrier in real-world practice. The stockings can be uncomfortable, especially in warm weather. They can be difficult to put on, particularly for older patients or those with arthritis. They can be costly, and sometimes, frankly, patients just don't like the way they look or feel.
So even though it works, getting people to use it consistently is tough?
Yeah, it's a huge challenge, and it significantly undermines the effectiveness of what should be a foundational therapy. Improving adherence is a major focus in CVI management.
Okay. What about medications? Do drugs play a role here in CVI management beyond maybe painkillers?
Yes, there's a class of medications called venoactive drugs, or VADs. These are mostly derived from plant extracts, specifically flavonoids.
Flavonoids, like in fruits and vegetables.
Similar compounds, yes.
Yeah.
They're thought to work in several ways: increasing venous tone, reducing capillary permeability and leakiness, improving lymphatic drainage, and importantly, inhibiting that inflammatory cascade we discussed earlier, particularly the interaction between white blood cells and the vein lining.
So they tackle the underlying process a bit.
That's the idea.
Yeah.
The most extensively studied VAD is something called micronized purified flavonoid fraction, or MPFF. It's a specific combination, usually 90% diosmin and 10% hesperidin.
MPFF. And does it work?
Good evidence shows it's effective in reducing symptoms like leg pain, heaviness, and swelling. And importantly, studies show it can actually accelerate the healing of venous ulcers when used in addition to compression therapy. It's not a replacement for compression, but an adjunct.
So it helps with symptoms and can boost also healing. Are there others?
Yes, there are other VADs available
Yeah.
in various parts of the world, like rudosides, horse chestnut seed extract, ruscus extracts, calcium dobisalate. They generally target similar symptoms like aching, swelling, or cramps.
And what's their main role? When are they used?
They're primarily used for symptom relief and reducing edema, especially in the earlier stages of CVI, C0, C3. They can also be used as an adjunct to compression or before and after interventional procedures. A typical course might be 2-3 months, maybe longer for more advanced CVI.
So those are the conservator and medicinal approaches. But for many, especially people with significant reflux in the larger superficial veins like the saphenous veins, actual interventions are often needed to fix the underlying problem. I know surgical stripping used to be the standard. What happened there? Why don't we hear about it much anymore?
You're right, surgical ligation and stripping, which literally involved tying off the main superficial vein at the groin or knee and then physically removing or stripping the length of it, was the traditional treatment for decades.
Sounds pretty invasive.
It was. While it could be effective in eliminating reflux, it was highly invasive. It usually required general or spinal anesthesia, involved significant postoperative pain, bruising, and swelling, hematomas, carried a real risk of nerve injury, particularly to the saphenous nerve, causing numbness. And the recovery was long, often taking up to a month before patients felt back to normal. Plus, perhaps surprisingly, recurrence rates were actually quite high over the long term due to neovascularization, the body growing new abnormal veins.
So painful, long recovery, and it might come back anyway.
Pretty much. That combination of factors means it's now rarely performed and has been largely replaced by much less invasive, highly effective endovenous techniques.
Endovenous meaning inside the vein. And these endovenous thermal ablations, EVTA, are now the modern gold standard.
They absolutely are. EVTA represents a paradigm shift in treating saphenous vein reflux. These are minimally invasive procedures that use thermal energy heat to deliberately damage and close off the problematic vein from the inside. The vein is left in place, but it scars shut and eventually gets absorbed by the body.
How is that done?
It's typically an outpatient procedure done right in the office under local anesthesia. The two main types are endovenous laser ablation, EVLA, and radiofrequency ablation, RFA.
Laser and radiofrequency, how do they differ?
With EVA, a thin laser fiber is inserted into the vein. The laser emits intense heat at its tip, essentially boiling the blood and damaging the vein wall as the fiber is slowly withdrawn. With RFA, a special catheter is inserted. It has an element at the tip that uses radiofrequency energy to heat the vein wall directly to a controlled temperature, usually around 120 degrees C, in short segments as the catheter is withdrawn.
And you mentioned local anesthesia.
Yes, a critical part of both procedures is the use of tumescent anesthesia. This involves injecting quite large volumes of a dilute local anesthetic solution mixed with saline and sometimes epinephrine all around the vein being treated.
Why so much fluid?
It serves multiple purposes. It provides excellent local pain relief. It physically compresses the vein around the catheter or fiber, ensuring good contact. And crucially, it acts as a heat sink, protecting the surrounding tissues, including nerves, from the thermal energy.
Clever. And the results?
The results are excellent. Success rates, meaning complete closure of the treated vein, are typically well over 90%. There's minimal pain compared to stripping, much faster recovery. People are usually back to normal activities within a day or two, and it's much safer.
Okay, a thermal ablation is the go-to for the big veins. And then there's chemical ablation or sclerotherapy. You mentioned VADs earlier. This sounds different. How does sclerotherapy fit into the picture of modern treatments?
Right, sclerotherapy is distinct from VEDs you take orally. It's an injection procedure. It involves injecting a chemical sclerosing agent, a type of medical deterrent or osmotic agent, directly into the vein.
What does the chemical do?
It works by deliberately damaging the endothelium, the inner lining of the vein. This triggers inflammation and thrombosis clotting within that segment of the vein, leading to its eventual fibrosis and obliteration. The vein collapses and seals off.
And you can inject it as a liquid or foam?
Yes. It can be injected as a liquid, which is good for very small veins like spider veins, or the sclerotin can be mixed with air or gas to create a foam. Foam sclerotherapy is more potent because the foam displaces blood better and has more contact time with the vein wall, so it's often used for larger varicose tributaries or slightly larger veins.
So where is sclerotherapy mostly used?
It's really the treatment of choice for those smaller veins. Telangiectasias, spider veins, reticular veins, and smaller varicose tributaries that might remain after a larger vein has been ablated.
Can it be used for the main saphenous veins?
It can be used for larger truncal veins, particularly using ultrasound-guided foam sclerotherapy, UGFS, to ensure accurate injection. However, and this is important, its long-term occlusion rates for these larger saphenous veins are significantly lower compared to thermal ablation.
Ah, so it might not last as long for the big ones.
Correct. There's a higher chance the vein will reopen over time. So while UGFS has a role, especially for treating tributary varicosities or some recurrent veins after other procedures, it's generally not considered the first-line treatment for primary saphenous incompetence compared to thermal methods.
Okay, that makes sense. And the newest innovations that are generating buzz are these non-thermal, non-tumescent methods. What's the rationale there? What's the big advantage for patients?
Right. The non-thermal, non-tumescent, or NTNT techniques were developed specifically to address the main downsides of thermal ablation, namely the need for multiple, sometimes uncomfortable injections of tumescent anesthesia and the small but real risk of thermal nerve injury, causing numbness or tingling.
So avoiding heat and avoiding lots of needles.
Exactly. The two main players here are cyanoacrylate, glue embolization, and mechanochemical ablation.
Glue. You mean like super glue?
It's a medical-grade cyanoacrylate adhesive, yes, specifically designed for use inside veins. The most well-known system is Venous. A catheter is used to inject small drops of this medical glue into the saphenous vein, essentially gluing it shut from the inside.
And the advantages?
A major advantage is that it usually only requires a single tiny local anesthetic injection at the catheter insertion site. There are no large volumes of tumescent fluid needed. Because there's no heat, the risk of thermal nerve injury is virtually eliminated. And this is often a big plus for patients in most cases. It does not require wearing compression stockings after the procedure.
No stockings. That's huge. People hate those.
It's a significant benefit for patient comfort and convenience, allowing for immediate return to all normal activities.
That sounds like a genuine game changer for patient experience.
Okay.
What about the other one, mechanochemical ablation?
Mechanochemical ablation, or MOCA, the main device is called Claravane, takes a different approach. It uses a special catheter with a wire tip that rotates at high speed inside the vein.
It spins. What does that do?
The rotating wire physically abrades or disrupts the vein lining, that's the mechanical part. At the same time, a liquid sclerosant is infused through the catheter right at the point of mechanical disruption, that's the chemical part. So it's a dual mechanism of injury.
And the benefits are similar?
Yes, like Venous, MOCA avoids the need for tumescent anesthesia and eliminates the risk of thermal nerve injury.
Okay, this sounds like there are so many options now, which is fantastic news for patients. But it also sounds potentially confusing. How do doctors and how should patients think about choosing the best approach, given all these choices? Is it just about the newest thing?
That's the critical question. It's true, the treatment landscape has become quite sophisticated, and the choice is now a much more nuanced, personalized one. It's definitely not just about the newest gadget. It's about balancing robust evidence on effectiveness and durability with individual patient factors and priorities.
Let's start with the big comparison. The modern standard, thermal ablation versus that old traditional surgery. Is there still any debate, or is there a clear winner?
Oh, the evidence here is absolutely clear and overwhelming. Endovenous thermal ablation, whether it's laser, EVLA, or radiofrequency, RFA, is unequivocally superior to surgical stripping for treating saphenous vein incompetence.
Superior in what ways?
While the long-term success rates in terms of just closing the vein might be somewhat comparable after many years, EVLA and RFA result in significantly less post-operative pain, much faster recovery times, far fewer complications like nerve injury, hematoma, or wound infection, and a much, much quicker return to normal activities and work.
So better experience, faster recovery, fewer problems.
Absolutely. Yeah. Consequently, all major international guidelines now recommend EVTA as the first-line treatment over open surgery. Surgery is really reserved for very specific, uncommon situations now.
Okay, so surgery's mostly out. Thermal ablation is the way to go for the main problem veins. But within thermal ablation, you mentioned laser, EVLA, and radiofrequency RFA. Are they largely the same, or are there nuances there that might matter to a patient?
That's a good question. In terms of overall efficacy, meaning how well they close the vein and keep it closed long-term, they are quite similar. Most large studies and meta-analyses show comparable high rates of durable occlusion for both EVLA and RFA, typically over 90% success at 1 year and holding up well over several years. The overall body of evidence really supports their equivalence and effectiveness.
So they both work really well. What about the experience?
That's where a clearer distinction often emerges, particularly in the immediate post-procedure period. Multiple studies have consistently shown that RFA is associated with less post-procedural pain, less bruising, less swelling, and a lower incidence of paresthesia, the pins and needles feeling from nerve irritation.
Less pain and bruising with RFA. Why might that be?
It's likely because RFA uses a more controlled and uniform application of heat delivered segment by segment at a set temperature, 120 degrees C. Laser, on the other hand, generates much higher temperatures right at the fiber tip, which can lead to more inflammation and potentially more collateral thermal effect. So while both are great, RFA often offers a slightly smoother, more comfortable recovery.
Okay, that's a useful distinction.
Yeah.
Now, what about sclerotherapy for the larger veins? You mentioned it's good for smaller ones, but what if we're talking about the main culprit, like the great saphenous vein? Does it stand up to thermal ablation?
For incompetent truncal veins, like the great saphenous vein, GSV, or small saphenous vein, SSV, the evidence strongly favors thermal ablation over ultrasound-guided foam sclerotherapy, UGFS.
Strongly favors. How big is the difference?
Long-term studies show a really dramatic difference in durability. For example, looking at 5-year follow-up, some major comparative studies have reported GSV occlusion rates around 85–90% for thermal ablation, but only around 50–60% or even lower for UGFS.
Wow, that's almost double the success rate long-term for thermal.
It's a very significant difference. The high rate of vein recanalization, the vein reopening with UGFS, when used on these larger truncal veins, means that symptoms in visible varicose veins are much more likely to recur, often requiring repeat treatments down the line.
So not the best choice for the main vein if you want it fixed long-term.
Generally, no. While UGFS is an essential tool for treating smaller tributary varicosities, often in combination with or after truncal ablation, it's considered an inferior option for the primary treatment of major saphenous trunk reflux compared to thermal methods.
That's a very clear difference in long-term success. Okay, now let's talk about those newest non-thermal, non-tumescent techniques, MOCA, Claravane, and Venous glue. How do they stack up against the established thermal ablation, which we know works really well?
This is definitely an exciting and evolving area with more long-term data emerging all the time. Let's take MOCA first, the mechanochemical ablation.
Okay, the spinning wire plus sclerosant.
Right. Multiple studies and meta-analyses comparing MOCA to thermal ablation have generally found that MOCA has a statistically significant lower anatomical occlusion rate at 1 year and beyond.
Lower success rate. By how much?
The difference isn't enormous, maybe around 10–15% lower success compared to thermal in some analyses, but it appears to be consistent. So while MOCA has clear advantages in avoiding tumescence and thermal risks and seems to have similar levels of post-procedural pain to RFA, it's generally considered a second-tier option for truncal veins due to that slightly lower long-term closure rate.
Second tier. Okay. And Venous, the glue method you mentioned earlier, with the advantage of no stockings, how does it compare on effectiveness?
Venous, the cyanoacrylate glue embolization, has demonstrated excellent efficacy in multiple trials, including long-term follow-up out to 5 years or more now.
As good as thermal.
The data consistently shows that Venous is non-inferior to RFA in terms of anatomical occlusion rates. For example, one major long-term study reported 5-year closure rates around 91% for Venous, compared to about 85% for RFA, in that particular trial, statistically equivalent.
So the glue works just as well as the heat, long term.
That's what the current evidence indicates, yes. But VenaSeal's standout advantages are clearly in the patient experience profile. Avoiding the tumescent injections, virtually eliminating the risk of thermal nerve injury, and crucially, as we discussed, in most cases not requiring those post-procedure compression stockings. This allows for the fastest recovery and immediate return to unrestricted activity.
So it sounds like we have a kind of hierarchy of efficacy, maybe, and then a spectrum of patient experience benefits layered on top.
Precisely. You can summarize it like this. For primary truncal vein ablation, like the GSV, endovenous thermal ablation, especially RFA for comfort, and VenaSeal glue offer top-tier anatomical success rates based on current long-term data. MSEA is a strong second-tier option, offering the non-thermal, non-tumescent benefits, but with slightly lower proven durability. Ultrasound-guided phone sclerotherapy is generally considered third tier for this specific indication, primary truncal reflux, due to significantly lower long-term durability.
Okay.
But the choice isn't just about the highest closure rate on paper. It's a nuanced discussion between the physician and the patient.
Right, it has to be personalized.
Exactly. It involves balancing that anatomical success data with the individual patient's anatomy, vein size, tortuosity, their specific symptoms, their tolerance for procedures, and the priorities. For instance, for someone with a very large diameter vein, thermal ablation might be preferred. For someone who places a very high value on the quickest, most comfortable recovery and absolutely wants to avoid compression stockings, VenaSeal becomes a very attractive top-tier option.
What a journey. We've really unpacked chronic venous insufficiency today. We went from that seemingly simple, relatable leg ache to understanding it as a globally prevalent, progressive, and surprisingly costly inflammatory condition. We've seen how it's rooted in that fundamental failure of our lower limb venous system to defy gravity, leading to sustained venous hypertension.
That high pressure being key.
And how that pressure sparks this complex, self-perpetuating inflammatory cascade that damages the veins and surrounding tissues.
And we've learned that the diagnostic pathway is now incredibly precise, with duplex ultrasonography as the undisputed gold standard. It gives us that essential anatomical and hemodynamic map we need,
guiding everything else. And the management approach has truly been revolutionized.
Absolutely. We've moved from just managing symptoms to fixing the underlying problem effectively.
Starting with those foundational conservative measures, leg elevation, exercise, weight management, and that critical, though sometimes challenging, cornerstone of compression therapy,
which remains vital, especially for advanced stages.
And then the dramatic shift away from invasive surgical stripping to this whole suite of highly effective, minimally invasive endovenous procedures.
Right. Endovenous thermal ablation, both RFA and EVLA, are the established gold standards, offering excellent long-term results and good patient experience.
With RFA maybe having a slight edge on comfort.
Often, yes.
Yeah.
And then the newest non-thermal, non-tumescent techniques are really changing the game for patient experience, particularly cyanoacrylate glue embolization, VenaSeal, offering equivalent efficacy to thermal ablation.
But without the tumescence, without the heat risk.
And crucially, often without the need for post-procedure compression stockings, which is a major win for many patients. MLCA is another valuable NT&T option.
So the modern approach to CVI is no longer a single rigid pathway. It's become a personalized journey, tailoring the treatment by balancing the highest levels of evidence with your individual anatomy, your symptoms, and your preferences for recovery.
That's exactly it. And as we look to the future, it raises some important questions, doesn't it? While our current treatments are excellent for dealing with the existing symptomatic veins.
What's next?
Well, what if we could actually halt or even reverse the disease process at a molecular level? Could we develop therapies that specifically target those underlying inflammatory pathways we discussed to prevent the progression in the first place?
Wow, tackling the inflammation directly.
Or perhaps more practically in the near term, how can we significantly improve patient adherence to simple, cost-effective yet profoundly beneficial conservative therapies, like compression stockings, given their massive potential public health impact if used consistently?
Yeah, bridging that gap between efficacy and real-world use.
And for the most severe cases, those involving significant incompetence or obstruction of the deep venous system, something we haven't focused on as much today, because current treatments are less definitive. The true frontier lies in developing reliable methods for deep vein valve repair or even replacement. Finding a true cure for deep vein CVI remains a major challenge.
Fascinating frontiers. So The next time you, listening, feel that familiar leg ache or heaviness, perhaps you'll remember this deep dive. You'll think a bit differently about what might truly be happening beneath the surface. Be informed, don't hesitate to talk to your healthcare providers about any persistent symptoms, and recognize the importance of this often underestimated condition. It's more common and more significant than many people realize.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.